Are we live?
Mine is, yeah.
Yeah. Okay. Welcome, everyone, and thank you for taking the time to watch and listen to our debate. I would like to start by introducing everyone in the group and what our jobs and roles will be throughout the debate. My name is Jessie, and I'm the introducer of the debate, and I will also introduce and talk about our pro side of the debate, which is ABA. Angela is the summarizer for the pros. Mandy is the summarizer for the cons. Katie is the researcher for both sides, and Christina is the illustrator for both sides. And finally, Adrian is the fielder and will answer the questions at the end. Applied behavior analysis is an intensive behavioral therapy that has been proven to show functional improvements that last in individuals with autism spectrum disorder. For this reason, ABA is considered to be the gold standard of treatment for individuals with autism spectrum disorder in most of North America. There have been 7 long-term and large-scale studies done that show that those children who receive at least 25 hours of ABA a week for 1 year will make tremendous gains. Some participants even achieve functioning within the average range for their age. ABA programs that are used for individuals with autism are supported by a significant amount of scientific evidence. However, even though ABA has years of empirical evidence, some occupational therapists, parents, teachers, and others favor alternative approaches like sensory integration and the medical model. We will be debating why ABA is better than the alternative models of sensory integration and the medical model. Our debate is informal, and here's how it'll work. We will start with the medical model. Angela, the summarizer, will explain a pro of the medical model. Then Katie, the researcher, will give some research on the positives of the medical model, followed by Christina with illustrations. Once the pro side of the medical model is complete, Mandy will step in with the negatives of the medical model and why ABA is a better option. Katie, the researcher, and Christina, the illustrator, will also add some points against the medical model and why ABA is better. Once the medical model is complete, we will follow the exact same format for the sensory integration method. I hope this helps you follow along during our debate. We will again introduce ourselves and our roles so you can follow along. I will now turn it over to Angela, who will begin the debate with the pro sides of the medical model.
The medical model holds that mental illness is a psychiatric disease with a physical explanation and therefore can be used with medical treatment. This model views behavioral abnormalities in the same framework as a physical disease or abnormality. Essentially, it treats mental disorders in the same way that something with a known physical cause would be treated, such as a broken arm. Supporters of this model consider symptoms to be outward signs of the inner physical disorder. With this, it is believed that these symptoms can be classified into a syndrome, then the true underlying cause can be determined and appropriate physical treatments can be delivered. The medical model addresses symptoms of autism through the use of medication or medical treatments. Medication is often recommended to decrease symptoms of comorbid disorders such as anxiety or depression, especially when behavioral therapies are not showing results. Medication can be easy to use, convenient, and show improvements of behaviors and skills quickly. Has been shown to improve social skills, increase focus level, and retain impulsivity, among other characteristics that are known to be common in autism spectrum disorder.
All right, I'm going to present the research for the positive and medical model side. The first article that supports the medical model as an effective treatment for symptoms of autism is Antipsychotics in the Treatment of Autism by Posey, Stigler, Erickson, and McKee. It was published in the Journal of Clinical Investigation in 2008. The article discusses the use of atypical antipsychotics frequently used to treat symptoms of autism such as irritability, aggression, self-injury, hyperactivity, and stereotypical behavior. The first antipsychotic discussed was risperidone. In one of the studies reviewed, risperidone was successful in reducing repetitive behavior and aggression in 8 out of 14 adults with autism or PDP, according to the Clinical Global Impression Improvement Scale, whereas the placebo group did not see any reductions in problem behavior. A pediatric study conducted by the research units on Pediatric Psychopharmacology Autism Network was also reviewed. This study had 101 child and adolescent participants with a mean age of 8.8 years. The subjects were rated according to the aberrant behavior checklist, and all showed a significant level of irritability, aggression, and/or self-injury at baseline. The subjects were randomly assigned to a group and either received a placebo or risperidone for 8 weeks. 69% of the subjects receiving risperidone were considered treatment responders, and only 12% of the placebo group responded with a decrease in problem behaviors, including stereotypy and hyperactivity. Several other studies conducted using risperidone showed improvement in the symptoms of autism. These studies resulted in the FDA approval of the use of risperidone for individuals with autism ages 5 to 16 to treat irritability. Posey et al. Also reviewed the use of olanzapine to treat symptoms of autism and PDD. In one 12-week study, the use of olanzapine in children, adolescents, and adults showed a significant improvement in hyperactivity, social relatedness, sensory responses, language, self-injury, aggression, irritability, and anxiety and depression, according to results from the CGI. Ziprasidone was also reviewed, which showed improvement in aggression, agitation, and irritability in 2 studies. One study showed improvement in the behaviors of 6 out of the 10 participants, and all 10 participants lost an average of 9.5 pounds over the 6-month study. Posey et al. Listed the limitations of the study, including the need for more studies to be conducted on the use of risperidone and other antipsychotics in less irritable children with autism. Risperidone was the only drug that proved to be consistently effective in the treatment of disruptive behaviors, so further studies on other antipsychotics need to be conducted. Additionally, further research must be done on the side effects of medication. The second article that supports the case for the medical model to treat autism spectrum disorders is the treatment of autism with low-dose phenytoin. I have to look that up. A case report by Philip D. Bird. This study was conducted with a 19-year-old male as the patient who presented with ADHD and autism. The participant had a history of irritability, impulsivity, aggression, and difficulty with social relationships. Once he had been administered the phenytoin, within 10 minutes he reported that it was easier for him to converse with others and maintain eye contact. Over the course of the next 2 weeks, the subject's family reported that social interaction had increased and there had been no aggressive outbursts. Eventually, after the patient had been taking the phenytoin for 18 months, it was reported that he had developed peer-appropriate friendships for the first time, and his violent outbursts had gone away. His AQ score dropped from 41 to 27, which is significant because a score of 32 or more means that the subject shows clinically significant autistic traits. So he actually ended below that level due to the medicine. The author suggested that further studies with more participants be done to see if this carries over to larger populations. Although this was just a single case study, it does show that medicine may be effective in treating symptoms of autism, including social deficits. And now Christina will show us the illustrations.
Okay. So here you can see the data from Antipsychotics and the Treatment of Autism by Posey et al. It has the summary of risperidone, olazepone. Sorry, I can't read this. Can you all see the whole screen or just part of?
No, just that part, just the data part right now.
Okay. Risperidone, olanzapine, quetiapine, and the symptoms that were improved included aggression, irritability, repetitive behavior, hyperactivity, as mentioned in the research. They did also have notable side effects, which included weight gain, sedation, and one participant also had a seizure.
Oh, my turn. Although medication may show an improvement in behaviors and skills, there are a number of cons related to this method of treatment. Medication can come with a variety of side effects, anywhere from mild to debilitating, which can even make for a lesser quality of life for the individuals taking the medication than to begin with. Additionally, medical treatments can be easily discontinued by parents or individuals taking the medication. And now our researcher, Katie, will talk more about the cons of the medical model.
One of the most significant is that side effects is the side effects caused by the medicine. In the article referenced earlier, antipsychotics own causes.
What happened?
We can't hear you.
Did you press mute on accident? Pause the time.
Yeah, oh yeah, causes. Oh, I have no idea.
Was your volume down from when others were talking?
No.
No.
Is something blocking your microphone?
I don't think so.
Oh, we can hear you now.
Oh, yay! Okay. That's weird, and I hope it doesn't happen in the real thing. Okay.
That's okay.
Okay. I'll keep going. Okay. One of the studies reviewed indicated that risperidone caused at least one aversive side effect in 13 out of the 15 subjects that participated in the study. Additionally, in the study conducted by the research units on pediatric psychopharmacology autism network, the subjects receiving risperidone gained an average of almost 6 pounds over the course of an 8-week trial, and an increase in drooling was reported in some of the subjects. Additionally, a study conducted on Wedeplin, 4 of which dropped the use 4 tolerance. 3 of the subjects returning with their participation experienced sedation, and 1 had a seizure after beginning the use of the drug. After the 2 participants that completed the study, both showed appetite and weight gain. Another study using Wedeplin actually had a participant show increased aggression and agitation as a result of taking the drug. Posey et al. Listed weight gain as the most significant side effect of the use of antipsychotics to treat symptoms of autism, especially in children and adolescents. It was noted that weight gain is a concern which can lead to many other medical problems later in life. Additionally, hyperprolactinemia, sedation, and adverse cognitive effects were noted as problematic side effects. Another evident concern related to the use of medication to treat autism is the fact that medication can be discontinued by the patient, family, or pharmacological company at any time. In a study done by Bird, the 19-year-old patient discontinued the use of his medicine after 4 weeks and stayed off of it for 9 months. His behaviors returned to baseline levels of aggression and difficulties in social interaction. Additionally, at the start of the study, additional medication was recommended to help with his aggressive outbursts.
Pause.
Oh no, again?
It's like so muffled for some reason.
Shoot. I don't know what's happening. I'm not touching anything different. I'm just.
Now I hear you.
That's so weird. Okay, you can hear me now?
Yeah.
Yes.
Okay. Maybe I'll sit at a table or something. Maybe it's like sitting funny on this pillow that it's sitting on.
Maybe.
Okay, I'll keep going. Additionally, at the start of the study, additional medication was recommended to help with his aggressive outbursts, but he denied the suggestion, saying that he did not care if he upset others with his behavior. The use of medication can be very unstable depending on the users and their families, as well as their circumstances. Inconsistent use of medication makes it a difficult treatment to maintain. Another negative to the use of medicine in the treatment of autism is that it is not able to significantly impact social skills or language in individuals with autism, which are often the most common side effects of the condition. Although the study by Bird showed some improvement in the subject's social skills, it was only a single case study and there was no evidence that this would carry over to a larger population or a different age group. Additionally, in the article, Treatments for Autism, Parental Choices and Perception of Change by Boker, D'Angelo, Hicks, and Wells, the authors surveyed, ooh, it's getting echoey now. Do y'all hear me?
Not too bad though.
No? Okay. The authors surveyed 970 patients of children with autism and other pervasive developmental disorders about their use of treatments for their children. Of the treatments, medication had the highest rate of discontinuation at 19.9%, or 281 people. This was reported to be due mostly to a lack of improvement from the medication. On the other hand, in that same article, ABA was reported to be the most widely used treatment amongst the survey results, with 37% of participants reporting use of ABA therapy. All reviews of ABA were high, whereas the reviews of medication were mixed. And now Christina will present the illustrations.
In this slide, you can see the information from Posey et al. Treatments for autism, choices, and perception.
We can't see it.
No, and you sound funny.
Progress and I fixed the PowerPoint to do what it's supposed to. When you see just me?
No, it's just a little blue like person icon
Okay, one sec. Or me, or neither.
Neither.
Neither. We're at about 13 minutes right now, also, by the way.
Okay. That's pretty good.
That's pretty good. We still have like a lot to do. We have the whole second half to the questions.
Yeah, so we're good.
That's good. So you paused it so we can like talk for a few minutes?
Yeah, I've been trying to pause it whenever
Good.
we.
So, okay, Katie, if this is like not too hard for you, then I seriously think it's so much better if we're clicking on one person's face like that.
Yeah. It
It's
hasn't been bad.
good. It's like so much clearer than it's like, I feel like every time I cough, it'd be like on my face and then back to you and like,
Yeah.
you know?
Yeah.
It would be great if we can come up with better transitions between.
I am writing them in right now.
Okay,
because
perfect.
I did not realize that till we started doing this, but
Yeah.
I feel like no one knows when someone's done. So then we should for sure be like saying, okay, and now to blah, blah, blah.
Yeah.
Yeah.
And I'll know when to switch the video feed too.
Yeah. So I'm like writing that in right now for each.
Okay, cool. Perfect.
So you all can't see the screen right now?
No.
No.
Okay, so it's set up properly now. I got the slideshow to pop up in a separate window so that it doesn't show the little mini slides at the bottom. So it's doing what it's supposed to do. It's just not carrying over to Google Hangouts. And it's letting me, when you screen share, I don't know if y'all have clicked, you choose which window to screen share. And it has it on there as a slideshow in its own window. So I'm not sure what else to do to make it populate.
Is there a way you could like just take a screenshot of the slide and show that instead? Would that, I don't know, I've never done it. I don't know if that would help.
You know, I'm not sure either.
Well, it should work. No, I don't know. I'll have to troubleshooting between maybe Windows 10 and this one. But I mean, the options are there the way they're supposed to be.
Maybe we could try tomorrow, like you and me try having you set up the broadcast, and then maybe it would screen share better since you're the one like in charge of it. I don't know if that would affect it.
Try that.
Also, I'm trying to, so right now I'm writing each like person's like transition thing, and I'm trying to make them all sound like a little different, so it's not always like, so now here's the summary or whatever. So when it comes to the illustrator, what should I say? Because I don't want to be like, and here are the illustrations.
Yeah.
For, like I said, Christina
Hard
will
for me.
facilitate this research by now showing some of the graphs and data from the articles. Like, is that
And
okay?
the graphs, a lot of it, like the first slide that you all saw, there wasn't a graph for that one.
Yeah.
And mostly anything I would say, the researcher just said it.
Yeah, that's what I'm confused about.
I just heard. I'm
Yeah.
not sure what I'm supposed to say.
Well,
Besides
maybe-
repeating what was just said.
Well,
Does it
maybe
have to
split
be-
up some of what Katie has to say.
Yeah.
Maybe you could say
Yeah.
instead, because Katie does have a lot. I feel
Yeah.
like.
I think so
way
much.
too much.
That would be great.
No, you have way too much. I think
Okay.
that would be perfect if you guys split up some of the stuff that, like, anything that is on that graph, like, if we can, like, kind of separate that to some of Christina,
Yeah.
Okay.
that'd be
Or
cool.
maybe we could, because I have one slide on, actually I have two slides on the Posey article and then one on the Bird article. So maybe I'll talk about Posey and then show the two graphs or the two charts. And then when you talk about, well, no, then that takes away the specific role, right?
Well, maybe like, could we like jump back and forth between the two of us instead of each having our own block. Like I could bring up the Posey article and introduce kind of stuff, and then you can talk specifically about the graph, and then I'll come back and do the bird article, and then you can talk specifically about the graph for that.
Yeah, that's what I was going to say, because Katie right now is saying a lot of numbers and statistics. And I feel like if we
Right.
just cut that part out, then Katie can just introduce the article and Christina can talk about the numbers more in detail based on the graphs she has.
Okay, that
Or-
would be better because
Okay.
right now there's not really much for me to say besides what she's saying.
Yeah.
Yeah,
and
right.
it's
And I
like,
think
oh, we're
Katie's
here.
talking a lot. Like,
So if
I
you
know.
just say this article showed results in this area, and then I'll bring up the chart and say it was 17% here, 20% there, that
Yeah,
kind of
that'd be
thing.
perfect.
Okay, that works. So we can
So-
reorganize that then.
Yeah,
Yeah.
I was gonna say, then do you guys want to just do that? I don't, since it's like your part, split it up the best way that you guys think is possible.
Okay.
And then we can practice it again before we actually do it or something.
Okay.
something?
So, okay, whatever you guys want to do now. But for the rest of this practice run, Katie, you should just finish.
Yeah. We'll just, yeah.
Okay.
To get the time. Okay.
So now we're at where? Hold on.
Do you want to just start with the sensory integration pros?
Oh wait, yeah, sorry, I'm caught. Okay, where are you? Is it my turn now?
Okay.
Yeah.
Oh, because Christina was about to do the illustrations, but we were saying we don't know how to do that.
Yeah.
Okay.
Do we want to do a short conclusion between the two?
That's what I was wondering also. Because now I just wrote in okay, now we're gonna begin discussing the pro side of sensory integration, but did we really end the other side?
We
Right.
may want to add, if somebody can add in something based on this research, ABA is better than the medical model because of these things we just said. Now we're going to move into the sensory integration or something, just a real quick 3 or 4
Okay.
sentences or something.
I
That's
can
what the summarizer has, right? So it's the same information?
yeah, no, it totally
Yeah.
is.
Just restating.
Okay.
Yeah.
Restating it. Do you want? So then, okay. The only thing is, so if I'm ending that and starting the next, then
That's kind of weird.
well, I just mean how do I segue into that? I'm okay, so then I end it, and then I'm and now I'll just talk about the. Is that fine? So I'm just
Mandy.
now-
I was kind of thinking Mandy would do it.
Who
Is that-
else? Yeah, I was looking at that. She's the conclusion person, right?
Right.
Or summarizer conclusion.
Yeah.
And
Or
then
I
you doing the
Or I
ABA
could do
pros.
it since I'm not in the actual
Oh, yeah.
debate part, then people
That's
won't get
true.
confused. I can
That'd
make
be good.
And it's not like you have to get more information. It's literally just a closing
Wrap it up. Yeah.
little
That'd be good.
sentence.
So
Okay.
should I do something in between the pro and the rebuttal also?
You may even just say and here's the rebuttal from the other side or something like that. I don't think we need a summary in there for that.
Okay.
That's what I was going to say. I think that transition's not as awkward.
Yeah, it's
So
not.
you-
I think it's just from
That's
medical
Okay.
to sense weird.
Yeah. But it may be a little bit clearer if in between the pros and cons you just say, those are the pros, now here's the cons, or whatever, something real quick, and then we can move on.
And then you want it to basically be what the introduction was for the conclusion.
Maybe just restated. Yeah. Here's.
Well, okay. So, but the only thing is, I don't think she has to say so. Sorry, losing my train of thought. I don't think she has to say the transition from pros to cons, because then it's gonna be difficult, everyone finding their place, since we're kind of trying to intro the next person.
Oh, yeah. Okay.
Person, yeah, just the person ending should just be and now we're gonna talk about the con side of this, and Angela or Mandy will summarize it or whatever. Just the
Okay.
person, finishing this. And I'm writing those in, so we'll know where those are.
Sounds
Okay.
good.
But
Guys, I think we're gonna have to do one more tomorrow before we do
I think
Saturday.
so too.
That's fine.
We can just do it like, well, do you still work until 6?
I normally don't, but I got a cover and I do work till 6. So
Okay.
I'm sorry.
No, that's fine.
Christina, we can't see you at all. Is that
You can't.
no?
Can you hear me?
Yeah. You're still just a little blue guy.
I don't know why. I can see myself in the little corner. Can you see me now?
No, mine's a blank screen
Oh,
for you.
I can see you now.
Now, yes.
Oh, nope, it went away. I did for a
I
second.
can see, like your picture in the bottom. It's not like you're not moving or anything.
Yeah.
Oh, yeah, okay.
Oh no. Something moved now. Hold on. That's weird. Everything looks normal to me. I don't know what happened. I didn't click anything else. Great. Save pages.
Wait, what's wrong?
Who started the call?
I did.
Can you click on me and see if that
Yeah, I had you
something
clicked,
throws me or
It's
something?
weird because we see you at the bottom.
but it's just a picture.
Yeah, oh, that's why.
Oh.
You're just
No,
blue.
I see myself moving at the bottom. I don't know what's going on.
That's so weird. I hate this.
No, I don't. Everything looks totally normal over here.
Well, it's
The audio video. It says this video call is running an app that gives the moderator the ability to control your audio video settings during the call, such as turning your camera on and off. The moderator also has the ability to eject you from the call.
Yeah, I just clicked a button that I shouldn't have clicked and then I X'd out of it, but I didn't mess with anything.
I'm going to transfer myself to another room so I can let my boyfriend have the TV. You can have the TV.
Do we want to just, oh, she left. Never mind.
Oh no.
Done?
Yeah, she's probably rejoining. I'm glad we practiced.
Yeah.
I'm working on the questions.
Oh, there you are.
Is it working again?
Yep.
Yeah.
Okay, I just
Yay.
left and came back. I don't know what happened.
Oh, that's weird. Okay.
I got way too
got it.
excited. I'm sorry, guys.
I feel like things like that might happen when we actually do our final, but I think it's okay.
Yeah.
Right. So if we drop out, just come back and don't say anything.
Yeah, yeah.
We may even want to have like chat open if we can like.
That's what I was thinking.
So if, like, we can like text or like type to each other like. Hey.
We can be like, Katie, no one can hear you. Take the computer off your pillow.
Yeah. Exactly. Okay. Do we want to keep rolling?
Yep.
That's good.
My turn.
Yeah.
Okay, so
Well,
we're-
this will be where Katie's gonna have a little conclusion sentence. So.
Or Jesse.
Yeah, I'll do that.
Oh yeah, sorry, Katie. You already have most of this.
I could talk more if you wanted, but I'm talking.
No, that's okay. All right. You fixed it to Jesse. Thank you. Okay. So I will start. Do you want to start the timer again?
Yep, we're ready.
All right. Okay. Sensory integration therapy has been widely used and accepted by both parents and occupational therapists as an effective treatment for children with autism spectrum disorder. Sensory integration theory hypothesizes that difficulty modulating sensory information can result in sensory defensiveness and under or over responsiveness to sensory stimuli, which may present itself in a client as developmental, learning, or behavioral problems. Many occupational therapists use sensory integration therapy, often a sensory diet, as a clinical treatment designed to help individuals process the sensory input received from their environment appropriately. In a survey of occupational therapists, 82% stated that they always use a sensory integrative approach for children with ASD, and 56% of parents stated that they had their child exposed to sensory integration techniques. Practitioners report 3 types of benefits from sensory integration therapy. They are enhanced ability to focus on materials, reduced challenging behaviors, self-injurious behaviors, and improved nervous system functioning, resulting in improved language and reading. And now Katie will take over for the research behind this topic.
The article, Occupational Therapy Using a Sensory Integrative Approach for Children with Developmental Disabilities by Schaaf and Miller, details the history of sensory integration. It was originally developed for children with learning disabilities by an occupational therapist, Jean Ayres, who believed that difficulty learning reflected a problem with neural functions, which for some children could be solved with help processing sensory information they receive. Sensory integration activities aim to incorporate sensory, motor, cognitive, and perceptual skills. It has been noted that children with autism may be able to improve their play, academics, and social skills through the use of sensory integration. Since its development, sensory integration has been divided into 3 groups: sensory modulation disorder, sensory discrimination disorder, and sensory-based motor disorders. Each of these groups can be addressed through different techniques in sensory integration therapy. As of 2005, over 80 studies have been done to assess the sensory integration model, and about half shows some effectiveness of treatment. Although not enough research has been done to find a definite conclusion about the effectiveness of sensory integration, the authors believe the field has tremendous promise. The article, Comparison of Behavioral Interventions in Sensory Integration Therapy and the Treatment of Challenging Behaviors by Delvin, Healy, Leader, and Hughes, compared the use of sensory integration treatment versus function-based behavioral interventions in addressing aggressive and self-injurious behavior. There were 4 male participants, all under the age of 12, who were diagnosed with autism spectrum disorder, which was accompanied by these challenging behaviors. Baseline data was taken, and then alternating treatment design was implemented with each of the boys for 10 days. The sensory integration therapy used materials such as a vestibular swing, trampoline, peanut-shaped ball, being wrapped in a blanket, deep pressure, tapping the body, chewing on a chewy tube, and/or joint compression. Behavioral interventions were developed individually for each of the boys based on the function of their behavior. In 2 out of the 4 patients, sensory integration therapy decreased the rate of aggression from baseline. Christina will now present the illustrations from these articles.
Okay. Can you see it?
Mhm.
Okay. This is the chart that shows in the comparison of behavioral intervention and sensory therapy in the treatment of challenging behavior. 2 of the 4 participants did show improvements with sensory integration therapy. Participants 2 and 4 had lower mean rates of self-injurious behavior after sensory integration treatment. The other 2, actually, yeah, the other 2 did not show effective treatment with sensory integration therapy. Participant number 1 actually had higher rates of self-injurious behavior, and participant 3 had no change in self-injurious behavior from sensory integration therapy.
Sorry, can we pause for a second?
Mhm.
Yep.
Do you want to present that stuff with the cons instead of the pros, like the bad side of it?
Well, it's the only thing that's for sensory. Like 2 of the
Yeah.
4.
But I mean, like present the 2 boys that were successful and then present the other 2 at the cons time? Because I go back through and talk about the 2 that were bad, that didn't have good results or whatever. Would that make more sense?
That makes sense.
Okay. Okay, sorry. We can go again.
Okay. Andy, you're up.
Oh, sorry. I was waiting on the transition. My bad. Okay. I'm the summarizer, and I will talk about the sensory integration cons. We have a responsibility to recommend effective treatments based on empirical evidence. Current research on sensory integration effectiveness is inconclusive. These are not well designed, and the studies that are well designed showed that sensory integration therapy did not benefit the individuals receiving treatment. The lack of empirical studies to show the effectiveness of sensory integration, there have been studies that compare sensory integration treatment in which sensory integration treatment was not effective, but behavioral treatments based on the functional assessment have been proven to be effective. With the research behind the cons of sensory integration.
Delvin et al. Discussed the results of their comparison of sensory integration versus function-based behavioral interventions, which had mixed results. For one of the participants, sensory integration actually increased the average aggressive incidence of aggression per day to a rate higher than baseline. For that same participant, aggressive behaviors decreased on days when the behavioral intervention increased. For another participant, there was no difference in the rate of aggression between baseline and sensory integration, so the treatment had no effect. For all the participants, aggression was reported at a lower rate on days when behavioral intervention was used instead of days sensory integration was used. In fact, the behavioral intervention reduced the rate of aggression to 0 for one of the participants and near 0 for the other 3. Behavioral interventions were more successful than sensory integration in reducing aggressive behaviors, which, according to Delvin et al., is consistent with previous research. The limitations of this study included the alternating treatment design, which could have interfered with the success of the sensory integration therapy, although the authors did not feel this was a real concern. Additionally, it was recommended that further studies be done using more participants to compare both types of treatment. Another article, a comparison of sensory integrative and behavioral therapies as a treatment for pediatric feeding disorders by Addison, Piazza, Patel, Bachmeyer, Milnes, and Otto, also compares the two therapies. The study had 2 participants, a 1-year-old boy and a 3-year-old girl, both of whom were admitted to a pediatric feeding disorder day treatment program due to sensory issues with food consumption. An occupational therapist was brought in to design sensory integration treatments to use with each of the participants, and a behavioral intervention was related to the function of escape was also developed. The results of the study showed that sensory integration was not successful in increasing the amount of food the child tolerated, and it also did not successfully decrease inappropriate eating behaviors. The behavioral intervention related to escape was successful in increasing appropriate eating behaviors. One limitation to the study was that non-contingent reinforcement was also available in the behavioral intervention, but not in the sensory integration. Sensory integration may have been made more effective with the combination of non-contingent reinforcement, but that would not have isolated sensory integration as the only intervention. Further research should be conducted, however, this study concluded that sensory integration was not an effective treatment for feeding issues. Christina will now present the illustrations.
Okay. And here are for the concentric feeding disorders. There are 2 participants in this study. Irma is the first participant and Mark is the second. You can see in both participants that escape and sensory integration are 0 for Irma in the percentage of bites accepted. And for Mark, they were highly variable with escape and sensory integration with escape. When the behavioral treatment of escape extinction and non-contingent reinforcement was implemented, you can see the bite taken is near 100% in both participants. And then when sensory integration implemented again, rates in Mark, and then near 0% of acceptance bites for Irma. And the best treatment phase final, again with the behavioral intervention, both Irma and Mark have near 100% acceptance rates for bites taken, and the behavioral treatment was definitely effective and the sensory integration was not effective. On the bottom 2 graphs, we are looking at the inappropriate behavior per minute displayed, and you can see in the baseline and for Irma, during the behavioral treatment of escape extinction, and non-contingent reinforcement, they dropped. Levels here, sensory integration was implemented once again, and inappropriate went up. And then when best phase treated once again, they were near 0. For Irma, you can see also similar results with the second participant, Mark. And Mandy's going to give our conclusion for sensory integration.
ABA is considered to be the gold standard of treatment for individuals with autism spectrum disorder in most of North America. As indicated by the study Treatments for Autism, Parental Choices and Perceptions of Change, ABA was used most by clients and also had high reviews in comparison to medical treatment alternatives. ABA is also the better choice when compared to sensory integration based on the fact that the studies lack empirical evidence and are not well designed. When all of the facts about each treatment are studied, ABA is the only one that has empirical evidence and reviews of from parents with ASDs backing it up. And now we have, and now our fielder, Adrian, will answer questions.
Which I'm still working on.
Okay, so that was 24 minutes.
Okay.
So that's pretty good.
Wait,
What
that
do
was
we need to do?
24 minutes?
Yeah.
Okay, that is totally fine. That's without the questions and without the last things that we all need to add. It will for sure be over 30 minutes.
Yeah.
I'm probably gonna add a couple more things, just like my parts too. I have another note though, so after just listening to everything, do you think that we have enough about ABA?
No, I definitely don't. That was my thought.
I feel like all we're doing is talking about the other two and saying why they're bad, but we're never really explaining why ABA is awesome.
Do we want to end with a totally just pros section for ABA?
Maybe we should. I feel like we need more about that. I don't know how ABA is our pro side if we haven't even been really.
Yeah, we haven't really explained it at all.
Okay. Then shoot. Okay.
Also, when she graded our outline, it says, be sure to provide a definition of all the models. Would you say that we did that?
I think that I did that because I remember she said that, and I feel in each summary I kind of explain what each of them are, sensory in the medical model, but I can try to do that more thoroughly.
And if we end with an ABA section, we can really define that one in there.
The
What were
only
the other?
BC review guidelines and ethical codes. We didn't connect those somehow.
Ethical codes.
I'm sorry, what did
The ethical codes we were supposed to connect somehow.
Oh no. Are we supposed to pick some ethical codes?
Yeah, we may just go through and add it to the summarizer parts.
Yeah.
Here's how this will hit a couple of these, and just do a couple. I don't think we need to hit every single one that it would talk about, but
Okay.
I think as long as we throw a couple in there,
yeah.
Okay.
it'll be fine.
Well, and I think maybe in the summary at the end that I just read, I feel if we put in the fact that those other, for instance, the sensory integration stuff is based on empirical evidence, not well designed, how that we can just throw in a code that's in violation of a code and then the code number and what it says,
That's a good idea.
Do that.
Okay.
And I'm trying to think of where else we could put them. Because do you think that's enough just in my one little part at the very end, or do we need more than that? Like I could probably put like 2 or 3.
I'll try to find some other spots to put, like we said in the summary.
Okay, and then I'll just, okay, and if I can find other places to put them in, I'll just put it in a different font. You guys see where I added them, and just make sure that everyone's okay with it.
Yeah, just
Okay.
make them like, let's make them like blue or something, and so we know where they've been added, and we can just like look them over. But what do we want to do about this ABA thing?
Yeah.
I mean, I put a little bit more in the introduction already. So do we want to just add it to the summary as well?
To the conclusion, you mean?
Yeah, the conclusion.
I think that would be a good place for it.
Just
That way we end with a strong ABA
in the
pitch.
conclusion? Okay.
Yeah.
I think only because, like for example, didn't she write in our stuff like, why is ABA the gold standard?
Yeah.
Didn't she write that as one of our comments? Like maybe we should like elaborate on that, like because you know it's been in all these studies, it shows all these whatever. I don't know.
So maybe in the conclusion we can say like the medical model is bad and it violates these codes and here's why. Sensory integration is bad and violates these codes and here's why. ABA is good. Here's all the research behind that. And then that.
That sounds good.
Yeah.
So that might work.
Okay.
What?
The only other thing on the outline was to go into more detail about the medical model, which I think we covered that.
Oh my gosh, I feel like there's so much detail.
Okay.
But it does say consider other aspects of the medical model other than medicine.
I have another article I can throw in there. I can like take some stuff out and add a little bit of that in.
Okay.
Well, if you do that, can you like tell me and I can add some of it to like the summary or something? Whatever article you like add, let me know. So, okay, we'll try to look for some ethical code stuff and put that in there. And then who is gonna like write more about ABA?
I mean, if we're doing it at the end, I guess I could.
It doesn't
'cause
have
it
to
is-
be a lot more. I think it's just like a little bit more like
In
like
depth.
yeah, like juice behind that research. Like why is it so good? Like you know.
Like,
Yeah.
because in the introduction, like I talk about that there is a lot of research,
Yeah.
but maybe you could state like 1 or 2 specific research articles.
Yeah, maybe.
Okay, and then I can just either go through those articles and then find a little bit more just to beef it up a little bit, or tie in your introduction a little bit more.
Mhm.
Probably both, and just beef it up talking for a little bit longer, a little more pro ABA, you know.
Mhm.
Sounds good.
That'd be good.
Okay. I mean, I think we're fine time wise and all of that. I think we just all want to make sure we add in this extra information.
Tweak it. Mhm. Are we all good with meeting again tomorrow at the same time?
Yes.
Yeah, that's fine.
Yep.
Yes.
Okay.
That's fine. I'm on the last question.
All right.
How long do you think the questions will take you to go over? Because we put 5 minutes. Do you think it'll take you that long?
Maybe about there.
Okay, that's perfect.
The last question that's on here, how do the dimensions of ABA influence the debate? That's my last one. I have everything for the other 2 questions, so this is the one I'm working on now.
Okay.
And PDF, but I should have it in tonight.
Okay.
Okay.
I'll work on the medical model thing tomorrow and have it in before we meet.
Yeah, I'll probably have mine before we meet tomorrow. It's probably not going to happen tonight.
That's fine.
Agreed.
Yeah, I'll look at some ethical codes and then just let me know if you add anything to the medical model.
Okay, I will.
Okay?
All right. We good?
I think we're good for now.
Okay. Thank you, ladies.
See y'all tomorrow.
Thank you.
Yeah.
See you tomorrow. Bye.